Thanks for coming to this lecture. Today, this is a regional lecture that is being sent out to a bunch of different sites throughout the state. Congratulations to the medical students on being done with yet another rotation closer to graduation, when your loans become due. So today I'm Dr. Potter, James Potter. I'm a senior anesthesia resident. Wave to the camera, Dr. Schrandt. This is Dr. Schrandt. Dr. Schrandt is an attending anesthesiologist here at NRMC. So we work together, and shortly we're going to have Beth Roberts, one of the fourth-year students who's interested in anesthesia. She's going to join us, and she's actually going to be our model. So today what we're going to do is we're going to talk about ultrasound anatomy. We're going to talk about ultrasound-guided central venous line placements, ultrasound-guided IV placements, as well as ultrasound-guided regional blocks, and some of the indications for that, and just kind of review anatomy. We know that a lot of the third years and fourth years have had this before, but it's always a good review, something to kind of talk about, and more of the clinical application of it. So, does anybody have any questions before we get started? Anything anybody really wants to learn about today? Specific things? Like, where not to put a needle? Where not to put a needle.
We're going to talk about that.
Yeah.
Okay.
And here's Beth.
Here's Beth.
I'll turn the time over to Dr. Schrandt, and
Beth, we're broadcasting to all your classmates. So, yeah. Okay. We're going to start with vascular stuff, so we'll start with
Do you want me to just lay down?
Sure. Or you can sit up. We'll start with probably radial stuff. So, anyway, for those of you listening out in the interwebs, this is Beth Roberts. She's one of your esteemed classmates, and so we're just going to use her as a model, and we're going to start today talking about vascular access and vascular issues, and using ultrasound as a tool to help with vascular access, because it could benefit any third-year student. It could be very, very useful, and it can help keep you out of trouble. So I'm going to start very simply just by looking at Dr. Roberts' radial artery here. So let's talk a little bit about what we're seeing here. We can see her, the bone of her radius there on the left side of the screen, and we see that small black circle pulsating in the center. Based on where I've chosen anatomically, that's supposed to be her radial artery, but how do we know? There's a few ways we can know. We can know because it's somewhere in the right location. We can know because it's pulsating. And another thing we can do to assess that, we can try to push gently on it with the probe. So I'm pushing down right now. And we can see that the vessel is not occluding. And in fact, when I put a little pressure on it, we can see it actually pulsating a little bit more. So that is, if you're trying to start an IV, that is one indication of don't go there because you're about to get in big, big trouble. We could also apply some color to it. And we can see it pulsating nicely. So when we're looking at this, and when you're describing what you're seeing to your attending, or when you're describing what you're seeing to your dictaphone, we have to use the right nomenclature. You spent a lot of money learning all this stuff. So when we're looking at the radial artery here, we say that we are looking at it in a short axis view. And when we talk about short axis versus long axis view, we are describing how we are seeing the intended anatomical structure on the screen, okay? And both views have their pros and cons, so I'm going to switch to a long axis view now. So I'm going to keep the radial artery in the very center of the probe, and I'm just going to start turning it 90 degrees. And I'm doing this one-handed. Let me see if I can. There, so you can see the radial artery just starting to open up there. There, that's perfect. So you can see the straight as an arrow radial artery pulsating there on top. This is a great view, and it's great for showing off, and it's great in the textbooks, but it can be somewhat difficult to use. Let's say if we were trying to cannulate this. So if we were trying to cannulate her radial artery, if we were going to put a catheter in it to monitor pressure, this is a great view because it looks cool and it makes you really look like you know what you're doing. But if we were going to introduce a needle in, it's very difficult to see the needle in an in-plane view with the probe and the radial artery in the long axis view at the exact same time. And you can see, even without me trying to drive a needle, it's actually somewhat difficult to keep her radial artery in view. Now, the advantage of this, if you were able to do it correctly, if you were able to introduce the needle directly under the probe, is you can see the whole needle, the tip, the bevel, the shaft of the needle come in, and you'll know exactly when you're going to get blood return, and you're going to know exactly where you are, and you get a beautiful picture to put on your refrigerator when you get home. When I do arterial lines, and when Dr. Parter does arterial lines, and Dr. Roberts here, we typically use this short axis view. And that's because if I approach the artery in an out-of-plane view, as long as the needle passes under the probe, I'm guaranteed to see the needle. I'm not going to miss it completely. Now, the caveat is I cannot see the needle tip. I'll see a very small cross-section of the needle, but you can use that to help guide where you want to be. So based on what we know about anatomy here, if I overshoot the artery just a little bit because I can't see the tip of the needle, there really shouldn't be anything there that I could contact with the needle that would spell absolute disaster. Okay. So I'm going to go on up the upper extremity here, and if you're not putting arterial lines as a third-year student, and I'm sure some of you are and some of you aren't, something you will get asked to do is to put an IV in a difficult, or not a difficult patient, a patient who's a difficult IV stick, okay? And when I get called here in Kirksville to put an IV in someone who's a difficult IV stick, which Beth clearly is not, and that's okay, I take my ultrasound with me, okay? And part of that is because patients can be difficult IV sticks for lots of reasons. Almost everybody has veins that are able to be accessed. You just can't always see them, okay?
You can still stick her multiple times as though she were a hard stick.
I could stick her multiple times. We do run needles down here in lecture sometimes, but today is not that day. So I'm just going to put the probe on her antecubital area. And looks like we got lots of vascular structures here. And we can apply the same techniques that we did down in her, near her radial artery. So we can see a large hypoechoic circle there in the center of the screen. It doesn't appear to be pulsatile, and when I push on it, it occludes really pretty easily. There's another one on top, okay? And actually, we can look a little bit deeper here, and I'll put some color on it. There's actually an artery, so it's very interesting to look at these. So we have a vein there on the very top, and an artery just directly beneath it. And I'm going to apply pressure, and this is interesting because we'll be able to, so we can see how much more easily the vein crushes relative to the artery. So this is one of my favorite things to do when I get called on a patient who's a bad IV stick. Nursing likes to use the ACs, which drives the anesthesia crazy, and that's okay, but if that's what you got, that's what you got. And if nursing can't see the IV, or can't see the AC vein, like physically with their eyes, it's very likely they haven't hit it with the needle, and so you can come in and really look like a hero and put that IV in. You do have to be careful if you're starting an IV using this technique because you have to make sure to use your aseptic technique. You probably want to use sterile ultrasound gel. You have to make sure that you cleanse the skin and do all these things. And you would approach it the same way you'd approach any vascular access. In this case, I almost always approach in a short axis out of plane view. And you just do like always. You put the needle in, you'll be able to watch it appear on the right or the left or in or just above the vein, and look for the flash in the hub of your IV start kit, and go ahead and thread the IV. Take that off so you can get some perfusion to your hand. That's better. Okay. All right. Okay, so Beth, we're going to have you lay flat now. So the next thing I'm going to examine is Dr. Roberts' veins in her neck. And just because you're a third or fourth year student, that doesn't mean that the neck is necessarily off limits to you. I wouldn't go complacently putting in internal jugular catheters as a third and fourth year student, but almost everybody, and Beth is a great example, has external jugular veins here, and all ultrasounded. It's a peripheral vein just like anything else, okay? Let's see if I can see it. There it is, right there on top. That's an external jugular vein. I can push on it, I can squeeze on it, okay? Now, Beth is by no means old, but she is skinny, so it makes it look really nice. The external jugular vein is a great vein to access on older people, okay? And that's because their saphenous veins have long been destroyed and ravaged by diabetes and venous insufficiency disease, but their external jugular veins tend to get really large because of things like heart failure and hypertension. Some of these are so big, you can literally put big old triple lumen catheters in them, like true story. So look for these. All right, Beth, I'm going to have you take a breath in and hold it in Valsalva down. So we can see it growing. Okay, go ahead and breathe. So if you're starting one of these on the floor, I like to have my patients Valsalva for me so I can look at it, and then I'll have them Valsalva again when I actually do the stick. Okay, so now we're going to keep moving on here. Okay. Yes, ma'am. So the question is, for those of you out on the interwebs, is if you're putting in an external jugular venous catheter as like an IV stick, do you need to position the patient a certain way, such as in Trendelenburg? I think the official answer is no. I think officially you don't even have to put a patient in Trendelenburg for a central line. I almost always do, because putting patients in Trendelenburg is going to increase the venous pressure and help that vein to distend. So it's actually putting someone in Trendelenburg or lifting their legs up or something is a great way to actually help find those veins, kind of help search for them. Good question. So we're going to keep moving medially along Beth's neck here. We can see a couple structures, and I've actually looked at Beth's vasculature here in her neck before, and she has a great example of internal carotid and internal jugular veins. And because of her body habitus, she would actually be very easy to cannulate. Putting in central lines is a lot of fun, and some of you are probably doing it out there as fourth years, but there are some severe complications that can occur. And one thing that's very, very important to note and be able to do is to tell the internal jugular vein apart from the carotid. And it's pretty easy here on Beth, because we can see a briskly pulsating carotid artery. I'll try and get them both colored here. And her jugular vein is actually looking a little bit pulsatile as well. So in this case, we can't 100% depend on color, but we can depend on anatomy. We know which of the two structures is typically located medially and which is typically located laterally. And we can apply a lot of the same logic we were using before. So I can gently press down, and we can see the internal jugular vein compressing quite easily. I'd have to press really hard, and in fact, I don't want to press any harder because it would hurt. her carotid is not compressing at all. And we can do some other things. So Beth, go ahead and Valsalva for me a little bit. It's huge. Okay, excellent. Let's lift her legs up. So we're going to lift Beth's legs up here, increase blood flow. Let's see what that does. There we go. So it's definitely distended a little bit from when we had our legs down. So this is one reason for considering putting your patients in Trendelenburg. The other reason for considering putting your patients in Trendelenburg for a central venous line such as this is to help to prevent air embolism. You can put a central line in either in a short axis view just like this, where you approach at a right angle to the ultrasound probe, and all you're going to see is one cross section of the needle. You can also decide to go the uber cool way and go in a long axis view. Let me see if I can find it here. So there's a long axis view. Oh, and this is exactly what I was looking for. So if we're looking at this, I can actually see I've perfectly sliced through the internal jugular vein and the internal carotid. And if I wasn't paying very much attention, you could see how very, very easy it would be for me to go straight into her carotid. It actually looks like one vessel here, but we're actually seeing two. So let me clean it up a little bit. There's her IJ. And I'm just, those of you who are out there on the other side, you probably can't see me. I'm moving the probe, like literally maybe a centimeter, and it's bouncing between the IJ and the carotid. And I'm telling you that, and I'm showing you that to demonstrate how easy it is to mistake one structure for the other. And the point is, it's very easy to cannulate the internal carotid when you're using a long axis view with a central line. It's happened to me. It's happened, I think, to everybody who does central lines. And it'll happen to you if you do central lines. Anything else to cover on vascular? So before we kind of switch gears to nervous system stuff, are there any questions that I can address right now? And that counts you all who are out at the outlying sites as well. Fire away. I know it's Friday. We just want to leave. Yes.
Have you ever seen like clot or embolus form like doing IJ or EJ access?
So
Like on the tip of the catheter or something, or multiple accessing of
you mean, have you ever gotten like a hematoma?
hematoma versus like clot?
No, I've never had, so the question is have I ever had an experience of an embolus with an EJ catheter? No. They tend to blow just like any other peripheral vein. They can and they will. They'll get big and puffy if you miss or blow it or whatever, just like it will down here on your hand. But I've never been caught by one of the internal medicine docs and say, hey, you give my patient a PE from the external jugular catheter that you started. Any other questions for, yes?
Is the direction of flow with the color Doppler useful, or does that just add a layer of confusion trying to remember which side the marker's on and is red coming toward you or going away?
So the question is, how useful is the direction of flow? And so that's when I put it on color mode, and I can see the red versus the blue flashing at me. And is that more confusing? I tend to not use the color with the direction of flow because I think it's a great way to assume something that's wrong. It's a great way to mistake an artery for a vein and vice versa, because if you literally turn the probe 180 degrees, it'll be the exact opposite. So there's probably some of you out there who are ultrasound gurus that use direction of flow stuff. I think it has a ton of utility in echo, of course, but whereas I don't do echo, when I color something, I'm mostly looking for a pulsatile blood flow. But as you can see, like when we looked at Beth's internal jugular vein, like it was even a little bit pulsatile. Now it was less so than her carotid. So I'm mostly just looking for, is this thing, whenever I'm looking at it, is it pulsatile? Justin.
Does the direction of catheter insertion really matter? Can I go, let's say I insert it distally versus in a vein?
So the question is, could you insert a catheter like an IV catheter in a distal direction versus a proximal direction? I don't know. I've never tried. I think it would be difficult. I think you would have problems with the catheter not threading because of the vein getting smaller. But I don't know that. Obviously, that's not a hard and fast rule. That's a great question.
Or the doctor doesn't matter.
Yeah, I can't see that it would. It just seems wrong.
Yeah, it'd probably still flow just fine. And
Yeah, the
stuff,
pressures would be the same.
Really valvy vessels, and if I
So if you go in the direction of
turn
the
them around, it probably would then.
Yeah, could be. It'd be something to try if you're like you're out of options. So you could try to flip it 180 degrees. Any other questions?
What about showing them some of your favorite places? So, patient, you're having a hard time besides the AC. Do you have other favorite places on the human body besides the AC?
I do. Okay. Yeah. So the question is, or rather the statement is, what are some of me as an anesthesia doc, me as one of the guys who gets called when nursing can't find a vein, where are some of the places I like to go to? Shoe off, please. It's okay. I'm sure you painted your nails.
No.
Okay. All right. Oh yeah, can you turn 180? So a lot of patients have, well, everyone has veins on the feet, of course. As we get older, they're not as good. Right here, just superior to the medial malleolus, there's the saphenous vein. That's a great vein to use. In older patients, it's a lot of time obliterated. It's great for peds. So if you have a little ped kid in the ER, look for it. A lot of times it's tough to see. So if you have a child with literally particularly thick skin, you may not see it, but you may need to ultrasound it. You can probably feel it. When we do peds upstairs, I have a very low threshold to go and use this particular vein. I think it's wonderful. I also like to use, there's a great one here, just on the, I guess it'd be the lateral aspect of the head of the radius. It doesn't show up visually very often, but it's a, what is that, the cephalic vein? Yeah. It's a really nice one here. For some reason, at least around here, nursing tends not to use it, and that means it's left for me. There are usually some nice ones here on the underside of the wrist. They usually don't get used either. They are a little bit, they're tender, that's tender meat there. So you may want to consider using some lidocaine to assist you. It may make your patient happier. Which ones am I missing, James? Yeah, older people a lot of times will have veins right up here on the shoulder. They're not easy to hit, but they do exist. So, anything else? Okay, I'm going to turn the floor over to Dr. Potter, And he's going to talk about identifying some of the nervous structures with ultrasound here. Let me get this off of me. People at the other side to like make his nasty voice stop. It's awful.
So again, as you're going out, you'll find times where maybe you're doing suturing or something like that it's not appropriate, or maybe you think, oh, somebody has a laceration on this part of their hand. My wife helps me get dressed in the morning too. It's kind of embarrassing, that's why I have name on bottoms and tops.
It's like those little alligators.
Yes, like my shoes, if you look on the inside, they say right and left, and I just live with it. So, but if you remember the brachial plexus, and the brachial plexus is never a fun thing to remember, but if you can remember the brachial plexus or pull out your netter again, there's a lot of great anatomy there, and so you can do selective nerve blocks. If you remember what part of the hand is innervated by which nerve, you can go ahead and do those. So we just wanted to start, this is very specific to anesthesia, kind of an introduction to what we do, what nerve blocks we like to do. So starting up at the top of the neck, you're all sorts of gooped up. Of course, figuring out what side is lateral and medial. So, yeah. Actually, why don't you go ahead and lay down, Beth?
We'll be inner element this way.
I like patients that don't move, to be perfectly honest. I don't like to consult PT. Okay. Did we freeze? No, we're good. Okay. So we're just going to start looking. So I like to come down and start on the clavicle. And as you can see, there's a nice, pretty artery right there. So subclavian artery. And yeah, we can put some color on that. And like, oh yeah, that's pulsatile. Definitely an artery. And so as we start to look around then, what we're looking for is a nervy structure. And when we talk about nervy structures, where's your nervy structures, Beth? Let's come up here a little bit. There it is. Okay, so Beth's got a great brachial plexus. So the structure kind of right in the middle, if you use your imagination, there's a structure right in the middle of the screen that looks like a revolver. If you were to a 6-shooter revolver, and it's just smack dab in the middle. On either side of that, those are probably some muscle bellies that we're looking at. And so what I'm going to do is follow that up, and it's going to, if you'll work with me here for a minute, it's going to turn into a stoplight. It's kind of a curved stoplight, but you've got 3 distinct nerve fascicles right there. So if you remember going back to the days of anatomy, and you remember your brachial plexus, everybody remembers the mnemonic Randy Travis drinks cold beers. And so right here, we're not at the roots, but because there's 5 roots that then divide into 3 trunks. And so this is what we would call an interscalene nerve block, where there are the 3 trunks right there between the anterior and the middle scalene muscles. And so in order to do this block, we would enter from the right side of the screen. We would watch our needle go in. You want to maybe put the...
I was hoping for a pointer, but we don't have one. I
So-
guess I could freeze it. Nothing matters.
Yeah,
It
so
doesn't
the
help.
top right of that corner is right at the on that middle fascicle of the trunk of the brachial plexus. So to kind of give you an idea, and then I'll follow it down that middle fascicle is then going to become the 6 shooter that we were talking about earlier. And so in order to do that block, this is a block that we would perform for somebody who was going to have shoulder or upper arm surgery. And in order to do that, we'd put a little bit of nerve stimulator on there. As the nerve got as the needle tip got close to that nerve, we would go ahead and turn down the nerve stimulator and inject local anesthetic deep to and superficial to these nerves. If we wanted to do a nerve block that was a little bit more distal to the shoulder, maybe we could easily come down here and block these nerves. At this point, we're kind of turning into, we're obviously past the roots and the trunks. We're more into the divisions, divisions and cords right here. It gets kind of murky. If we wanted to do distal elbow surgery or hand surgery, we could do an axillary nerve block. So we'll have Beth bring her arm up. Now, I remember the first time I saw an axillary nerve block done, it was done without ultrasound. And the way that they used to do these is they would do what was called the Transarterial Technique. Let me find our artery here.
I saw it.
So here's our artery. Beth's got really good anatomy. And so what you would do actually on the Transarterial Technique, I'll point these out. So again, using the top right corner of my box here, that's a nerve, that's a nerve, and that's a nerve. So these 3 nerves, you have the radial, ulnar, and median nerves. Yeah, and musculocutaneous nerve right there, right? Dr. Schrandt is. Oh, okay. I can't get it. So it's kind of just right below there. It's either that one, and with the musculocutaneous nerve, it's more of a kind of a guess where you're going to block. But what they would do with a transarterial approach is you would palpate the artery, and then you would stick a needle into the skin and start aspirating. And as soon as you got blood that started to come back, you're aiming for the artery. And so you're going to go through the artery, get blood, and as you continue to aspirate, once you get to the other side, the blood stops and you know you're in the right spot. And then you inject. Does anybody else find that a little bit disconcerting that you're aiming for an artery to do a nerve block? I just, there are moments I wonder. It worked, but, and then so you would get the back side, the posterior side of the artery, and then you would withdraw and you'd come back out and again aspirate, and then when it stops aspirating on the other side, then you inject more local anesthetic. So that's where we could block any of those nerves that then go down to the hand. And so let's say, you felt like somebody had a hand injury that you wanted to do stitches on, we'd be happy to come in and, talk to us about, whatever reason you don't feel like you could, like it's a significant injury to the hand and you need more local anesthetic than you feel like you could appropriately infiltrate into the hand. Call the anesthesia department and be like, hey, could you come do an axillary nerve block for us? Because we can, do an axillary nerve block with about 15 cc's of lidocaine. And it will, give you all the relief that you need. And if you're going to have to do more than that, it may be worth calling and asking anesthesia to come in and help with those kind of things. You could also come down. We reviewed anatomy, but you can do a median nerve block by finding the median nerve in the muscles of the forearm. You can also just do a radial nerve block or an ulnar nerve block down distally as well. Just select the nerve that you need to make fall asleep and then go ahead and do that. So any questions about upper extremity nerve blocks, ultrasound stuff? You want to see anything else? I'll show you get the scoop out of your armpit. So this is the radial, obviously going back to the radial artery. The radial nerve is very small. It was kind of hard to find the other day. So we'll jump over here I'm going to grab a little bit more ultrasound gel. Beth's going to have a bath after this just to get all the gel on. That's right. Thanks, Dr. Jackman. So here's, right there in the middle, that's probably your median nerve right there. So if you wanted to provide, send a good block to the median sensation of the hand, you could just inject a little bit of local anesthetic right there, right over the middle of the wrist. And you can kind of see how that looks more like a tendon or something. And then to go over to the ulnar, there's the ulnar nerve right there. Kind of looks like you see the ulnar artery and then just lateral. Make sure what side's what. So just immediately on the left-hand side, on the right-hand side of the screen to that artery right there, that's most likely the nerve. You see kind of how it has a honeycomb appearance to it. That's going to be your ulnar nerve. And so if you wanted to, provide a good block to the ulnar distribution of the hand, you could just infiltrate some local anesthetic around that nerve and, 5 cc's, and you would have a good block to that part of the hand. Okay. So that's upper extremity stuff. What time is it?
It's 20 till.
20 till.
Yeah,
So
5 to 10 minutes.
do we have any questions popping up over the chatter box?
Nothing in the chat room I can see at the moment.
Okay.
Does anybody from the outlying areas or anybody here locally have questions, or mostly for Dr. Schrandt?
Yeah. Okay.
Did you ever used to do kind of more of the nerve blocks and things just by palpation?
Yes, absolutely. So,
Way back.
Sorry,
this is ultrasound.
Yeah, so the question is, did we ever do nerve blocks without an ultrasound? And the answer is absolutely yes. All of the anesthesia books describe how to do them without ultrasound. A lot of it has to do with you have to know your anatomy very, very well. You still have to know your anatomy when you're doing ultrasound guided blocks, of course. But it was a combination of knowing your anatomy. And we also use nerve stimulating needles. Do we have one in here? Make it lucky and have one. Anyway, so we're actually able to run a small amount of electrical current through the nerve stimulating needle. And when the needle tip gets close to the nerve, it stimulates the nerve, and we see muscle twitch. So it's one way to know, yes, you're aiming for the right target, you hit the right target. We actually, here in Kirksville, we actually use ultrasound plus a nerve stimulating needle. It's probably overkill, but it certainly is not going to hurt anything to use that nerve stimulating needle. Other questions out there? Yes.
With vascular access, could you explain how you evaluate someone's volume status, possibly ultrasound,
So the question has to do with using the ultrasound to evaluate someone's volume status, and we actually have a study going about that right now. There is some literature out there with assessing someone's IVC or IJ and looking at the cross section of the vessel, and then doing something like raising their legs up, and basically giving them an auto transfusion, and to see how that changes. Quite frankly, I'm not familiar with that literature, but it is an area of study, and of course, everyone's looking for that magic diagnostic tool that can call hypovolemia, which we're all still looking for, of course. So, anything else? Are we going to do anything on our lower extremity?
I wasn't sure if we had time to.
We can do an adductor canal look real quick. It's the hot new thing right now. So, can I get here? Okay. Oh, you pick.
Which would be easiest for you?
Probably this one, based on how everything is arranged. So probably the last, oh, can you spin around? Yeah, so the camera can see. So the last thing we'll show you today is the anatomy around the that we look at when we're looking at what's called an adductor canal block. Adductor canal blocks have skyrocketed in popularity over the last few years, mostly in the setting of using them for total knee arthroplasty because literature shows they provide analgesia and they also retain quadriceps motor function. So in the days where we are now with this enhanced recovery and patients are expected to stand up 20 minutes after their total knee arthroplasty and have no pain and walk out the next day, this block has become very popular. That is in contrast to a femoral nerve block, which is we typically place a femoral nerve block up in the inguinal area. That, of course, has great pain relief to the anterior aspects of the knee, but blasts the quadriceps. So if you put a femoral block in somebody, they will not be walking the rest of the day. So, get a little depth here. So I'm just looking for the Sartorius muscle, which is typically boat-shaped. And we're looking for like, you can see the femur, we're looking for the cross-section of like a boat. I think that might be it on her. There it is. So Beth did not read the anatomy book for once, okay? You can see her Sartorius right there in the middle of the screen. And let's see if we use up the artery. There it is. There's the femoral artery down there. Let me give a little depth here. Okay. So we can see the Sartorius muscle there in the very center of the screen and the femoral artery just kind of below it. If you can, you may or may not be able to see from the camera. I'm about mid-thigh. And so this is what's called an adductor canal block. And the nerve, I'm going to try to use I'll use the bottom left corner of the box here. It's going to reside in here somewhere. It might be this little lit up structure. It might be this little lit up structure. The point is, what we do is we flood this area with local anesthetic. You think, well, that's easy for you guys to say. Well, just by putting local anesthetic in, it causes what's called a hydrodissection and actually can a lot of times help us actually visualize that nerve better as we get the nerves and the muscles and what other fascia separated from the nerve. So frequently we'll put a little bit of local anesthetic in and then we can actually see the nerve a little bit better. But this is exactly what we're aiming for. So when you're out there on your rotations and people are talking about these adductor canal blocks, this is the spot, this is the block. We do them on occasion. They're useful for much more than total knee because this nerve goes on to be the saphenous nerve. They're actually quite useful if you need some analgesia to the ankle over the medial malleolus, and that's one way to tell that you've had a successful block is you'll have analgesia over the anterior aspect of the tibia and over the medial malleolus. If we were to follow this all the way up, it would, of course, we could follow the artery and it would just go up to the inguinal area and into the femoral triangle where we would put a femoral nerve block. All right, it's 12:45. So that's the last thing I'm going to show you on Beth for now, unless somebody wants to see something else, whether it's somebody here in Kirksville or someone from one of the outlying areas. We'll open the floor for 5 minutes of questions before you have to go back to rotations. Anything at all? Anything in the chat room or the cyberspace? Yes?
Apart from using the ultrasound to just find veins when you're trying to do peripheral IV access, especially at night, so we don't have to call you guys in, Do you use like an inline or short axis view to actually place the IV catheters? We've tried that, but then we have trouble once we get it in. The catheter itself is not picked up on the ultrasound, but the needle is.
Mm-hmm.
So I just want to know if you have any technical tips to help maneuver those things.
Yeah, so the question was, how do I start peripheral intravenous catheters under ultrasound, and how to deal with some of the problems that can happen with them? So first of all, the view that I use is a short axis out of plane view, just like if I was doing an arterial line, just like if I personally was doing a central line. The main problem that you're going to have with that is, like, no duh, you can't see the tip of the needle. So one way to kind of see the tip of the needle, because, I mean, we're dealing with a really small needle, a really small vessel. Like, it's so much easier to do a central line with ultrasound than it is to do a peripheral line, because the target is, like, literally like 10 times bigger, okay? So the problem is you can't see the needle, and the vein is somewhat tortuous. It's not a straight shot like the central line is. And so one way that you can use to help, like, see where the tip of your needle is, you're coming in, you look for that needle, that cross-section of needle shaft. Is it to the right of the vein? Is it to the left of the vein? Or medial lateral, I guess would be the appropriate verbiage. And when you're seeing it just over the top of the vein, okay, if it's over top, you're like, well, I see the shaft of the needle, it's over the top of the vein. You have probably gone too far, meaning your needle approach is too shallow. You might strike the vein, but it's going to be a long ways away when you actually cannulate the vein with the bevel of the needle, and you're not going to have very much slack to actually thread the catheter. So the catheter in that juncture might be like literally a millimeter or something in the vein, and that's better than nothing, okay? But that counts as tenuous. So one way that you can actually help see the tip of the needle in a short axis view is when you're bringing it in, if you're able to see the wall of the vessel, like, depress, okay, that means I'm close to the tip of the needle. So if you bring it in and you're tapping it around, you can see the actual upper wall of the vessel, like, compressing and pushing down. Like, yes, you can't technically see your tip, but you know you're close. And so you can compare your ultrasound probe to where you went through the skin and how much slack am I going to have there for threading my catheter. That's one thing I would recommend. And that's easy for me to say because we do it a lot, right? So. Oh, yeah, something else you can do if you have a patient with bad venous access. There's been multiple sticks, and you're like, boy, I can only find one or two good ones here. Dr. Potter suggested, and he's right, you can get a little lidocaine, put it in a TB syringe, infiltrate a small wheel. Okay, if you think, boy, this is all she's got, or there's a potential to be making multiple passes at this, you can put a little wheel of lidocaine in there and pass through it. It hurts just as much as a regular stick. Okay, there are some institutions that use lidocaine on every stick. I don't think it's necessary because it hurts just as much one or the other. But if you're making multiple passes, definitely consider some lidocaine. Anything else? Nothing else in Kirksville? Is there anything else from wherever? Okay. Thanks for coming. Go back to your rotations. Thank you.